Welcome to the AOA Future in Orthopedic Surgery podcast series. This AOA podcast series will focus on the future in orthopedic surgery and the impact on leaders in our profession. These podcasts will focus on the vast spectrum of change that will occur as the future reveals itself. We will consider changes as they occur in the domains of culture, employment, technology, scope of practice, compensation, and other areas. My name is Doug Lundy, host of the podcast series. Joining us today is Dr. Lisa Lattanza. Dr. Lattanza is the chair of the Department of Orthopaedics and Rehabilitation at the Yale School of Medicine. She obtained her medical degree at the Medical College of Ohio, did her internship at the Harbor UCLA Medical Center, her residency in orthopedic surgery at the University of Missouri, Kansas City, and her fellowship in hand surgery at Columbia College of Physicians and Surgeons in Roosevelt Hospital. She joined the School of Medicine at Yale in September of 2019 and is currently one of the 7 female chairs of orthopedic surgery in the United States. Dr. Lattanza, welcome to the podcast.
Thank you, Dr. Lundy. It's a pleasure to be here.
Our subject tonight is generational shifts and worldview changes. You know, this is a pretty broad topic that we could take anywhere we want to take it. And I know that you have a significant amount of interest and exposure in this area. Y'all have 5 residents per year up there, right?
Yes, that's correct. 5 per year, so 25 total.
Yeah, so you're surrounded by a lot of younger people who are probably constantly challenging worldviews of your older attendings and other folks around there, which is good. I mean, it's always good for us to be challenged on that and move along. So give us your thoughts overall of how you feel, and we could take this in many different directions, of how changes in worldview, changes in generational shifts will affect us as orthopedic surgeons as we move into the future.
Well, I think this is a really interesting topic, and I would love to have been able to have this question asked once a decade for the past 40 or 50 years, because I can remember as a resident, some of my attendings saying, they don't make residents like they used to. We used to do X, Y, Z. And all of those things were probably true. And, it's the same thing with your children, right? They're constantly pushing boundaries. Not that I'm comparing residents to kids, but, my kid's 24. So he's constantly pushing me on technology and, how I see things and, electric cars or whatever it might be. And so I think that this is a topic for the ages and should be revisited often. I think it's really easy to say younger generation doesn't have the same values or the same work ethics or things like that. And I really don't see that. I see our residents wanting maybe a slightly different life for themselves that's more balanced than what we might have had. And I think that that's a good thing. However, what I find really interesting is I also run a department with lots of young assistant professor attendings. And I will tell you, there's no one that works harder than this group.
Right.
So what they think they might want in residency and what I see from a productivity standpoint, clinically, research, education, I don't see it as being any different than my generation or, the generations in between the youngest faculty and my generation. I think that they've learned to do things a little bit differently, but the work ethic, the values, the attention to patient care, all of those things are the same as what we profess as part of, our generation. And those are my observations.
Yeah, I assume I'm going out on a limb on this, but I assume that you and I are both Xers, Gen Xers. And to your point,
Sorry,
we were all...
Thank you for the assumption, but...
Well, I'm going to stick with Gen X, even though I'm what we call a tweener. I'm between that and the boomers, but I'm going to stay with X. A matter of fact, because I read the book When Generations Collide, and I had every bad tendency Gen X has, so I think I own it, even though I might be on the edge. But we're often told, to your point, you all better watch out, because once the millennials come in, those of us in our generation, God help us when we break our hips, because nobody's going to be around to take care of us, and they're not going to work hard to do anything. And to your point, and I would totally back that up, I'm seeing the exact opposite. I mean, I see folks that, almost rue the 80-hour work week. I mean, they're almost like, gosh, I mean, I wish I could stay on and do this. I'm like, no, 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 no. You can't violate that. Go home. It's not, they get a bad rap.
I think so too. We've put some boundaries in place, like you've said, the 80-hour work week. And, there's always going to be those people, whether they're faculty or residents, that are going to do the bare minimum. But by and large, what I see is exactly what you're talking about. People that want to be there for the cases, aren't looking to check out, showing up for things like we would have before the 80-hour work week. And like you said, having to send people home. I think one of the differences I see, it's not generational from a standpoint of an underlying difference in values. It's the way we've designed medicine in this time period that really is shining a light on some of these changes. And what I mean by that is there was no such thing as a physician assistant or nurse practitioner when I was a resident, when I started in practice. And now those support people are part of our daily lives, and they take on roles that we would have taken on as residents.
Right.
But those weren't things that were necessarily valuable to our education or valuable to patient care. You could argue that some of it is that maybe the residents don't know their patients as well because they have other folks that are doing rounds for them to free them up for other activities. And that might be true. But there's also an upside to that where they're, able to get to the ORs on time because they're not doing some of that rounding, or they're not getting up at 3 a.m. so they can round from 4 to 6 or 6:30 and be at education or be in the operating room. So I think that, some of these changes that have been implemented weren't implemented by this generation, but they're good changes, yet it does shift things a little bit. And an argument can be made on either side, whether it's good or bad. And I don't think it's either. I think it's just different.
Do you see any changes in how you incentivize your residents versus your assistant professors versus your associates? Is there any changes or different nuances to how that works out?
That's a great question. I think there's probably a difference between residents and faculty for sure. And, the residents' primary motivation is education. And, being able to become competent surgeons and get their hands on enough cases, being allowed to do enough that they get the repetitions to be safe in the operating room, and getting a graduated independent so they feel like they're able to do things by the time they hit the door at graduation. So I think that's, incentive for the residents, and making sure that they're in a supportive environment, trying to get rid of some of the old school ways of orthopedics where we're not beating up on people, we're really teaching and supporting. And I find that, that's very motivating in terms of who the residents choose to work with or want to work with, and whether they want to put in the extra time. I think young faculty, the motivation is having a culture that supports both their professional and personal lives, having a culture that allows them professional growth, that provides resources that are necessary for leadership development and research, and becoming part of societies, and, taking those next steps in their careers. And that's, a little bit different from assistant to associate professor, but not terribly different. It has to do with, providing not only mentors, but sponsors, and having those things in a really organized way, instead of just, and some of it happens organically, but you need both. So I think that, and, money is a motivator for some, but that's not the only motivator for at least academic faculty. There are many other motivators, or else, we could probably all go find a job where we make more money.
So how do you see this happen in the future then? So what's it going to be like when you and I come up with our displaced femoral neck and we have to have one of our younger colleagues take us on the fracture table or fix our hip? What's that going to look like? Is that any different from now, or what's that group look like?
I'm hoping one of my smarter young faculty figures out how to prevent that. So we'll start there.
You're going to put me out of business.
Exactly.
But you're right. You're right. But how's that going to look,
I don't think it's going to look a whole lot different than it does right now, except for, the elephant in the room, which is the surgeon shortage that we're running up against.
Right.
And, we're already on the cusp of that in orthopedics. I believe it's 30 to 35% of orthopedic surgeons across the country are within 5 years of retirement age. That's a scary number.
Yeah.
And, we don't have the ability to change that. Those that are in power that have the ability to change that for whatever reason have decided not to. So what I see, and I think where the shortages are going to come in, is not because we have a workforce that's lazy or has a different work ethic than we did. It's because simply there's not going to be enough surgeons. And that's going to put a whole nother stress on the system that we're already, starting to see. The only way around that is to leverage physician assistants and nurse practitioners probably to do more, to free up surgeons to be in the operating room. And so I think that we need to address that too, because physician assistants and nurse practitioners coming out of school are not orthopedic specialists. And I'm not sure that we're doing the right thing by saying that we can on the job train them if we have an expectation that they're going to be doing a lot of stepping in for a fully trained orthopedic surgeon, so that surgeon can be more in the OR. I think that's going to be the difference. So division of labor may change. I think one of the things that scares me is that there's all kinds of talk, and maybe a preview for the meeting this summer. Across states, there's talk of allowing increased responsibilities for non-MD, non-surgeon orthopedic providers to step in and do, quote unquote, more simple procedures. For example, that came up in my state, or other specialties, podiatry, chiropractics, physical therapy, stepping more into the role of what's traditionally been filled by an orthopedic surgeon. And I think it's interesting because there may be some places where that's appropriate, and there may be some places where that's completely unacceptable. And we have to be at the table to help make those decisions.
For scope of practice issues, right? Yeah.
Exactly.
Now, you're program chair for this year's annual meeting in St. Louis.
I am. Yes, that's correct.
So this is really cool. We can ask the program chair, because the AOA always gets on, not always, but many times is touching a lot of the edgy kind of subjects that are like, wow, that is really fascinating. That's cool. I'm not going to see that anywhere else. Anything that we're talking about this year that kind of lends into this future in orthopedic surgery, or specifically with the generational shifts or worldview changes?
Yeah, absolutely. The one that comes to mind is the one that you're moderating on YouTube.
That was a little self-serving. I'm sorry. Yeah.
Unionization. Unionization. And I think that, the topic on resident unionization is very timely and goes right into what's the future of orthopedic surgery. And, taking that a step further to places that are at least talking about unionization as faculty or as practicing employed surgeons and physicians. So I think that that's a very timely topic. I think there's, the topic of, are we choosing residents in the correct way? Is there something, about the way we do that could be improved to help us with the future of orthopedic surgery? And I think that the answer to that is likely yes, but I'm really looking forward to that discussion as well, because I think that to solve some of these problems, we need a really diverse set of people coming into this specialty that traditionally we have not had. Diversity from every different way you can define that word: gender, ethnicity, sexual orientation, even where people trained. A lot of academic centers get into these habits of hiring back their own people. That does not breed diversity of thought. So we need as much and as many different kinds of diversity as possible in this specialty, which we have traditionally not had. And we have traditionally kind of brought up the rear in medicine as being the least diverse. And I think that in and of itself will change the future of orthopedic surgery.
Yes. Yeah. Changing more to match the demographics of the people that we serve.
Right. It will help with, health inequity and access to care. It will help, define some of these problems better and have different perspectives on how we address things like scope of practice and physician shortages and even technology.
Right.
So, technology is part of the future of orthopedic surgery for sure. And, things like artificial intelligence, augmented reality, 3D printing, all of those kinds of things I believe are the future of medicine and the future of orthopedic surgery. And so we need also people from those backgrounds and with those types of skill sets to help bring the specialty forward.
Now, I want to get into that, but before we go there, let me finish touching on Worldview for a minute. One of the joys that I have in my job is to try to play complete poker where they have no idea where I'm coming. So they're actually telling me the truth rather than what they think I want to hear, and kind of delving into the worldview of this generation, which is pretty much could be my children in terms of their age and age difference between us, and trying to see the world through their eyeballs and understand that. Do you have any thoughts about how the changes in worldview occur with that? I mean, they grew up in a world where cell phones and technology was right there, whereas with you and I, it all developed during then. So they have a whole different view of the world, how things occur, and all these things are developed.
Yeah, I think that the first thing is probably that there's a faster adaptation to technology than perhaps previous generations, and they're not as afraid of it or hesitant to start using it in practice, which can be both good and bad. I mean, the old saying is never be the first or last to use a new thing. I think there's probably much more on the end of, be the first or among the first to use something that's new. I think that the playing field has been leveled a little bit on development of new technology within orthopedics, because a lot of the new technology is, computer-based type of things that lots of people have skill sets for. It's not just about, I need to make a better widget for a widget that already exists. I'm going to tweak one little thing and call it something new. I think that we're on the cusp of some really new innovation in orthopedics. It's not just about having a new widget. And I think that this generation is trained and poised to do that much more than previous generations have been. I think that what I see coming through medical school and the people that end up applying to orthopedics, they have a much broader background in lots of different areas of computer science and engineering and physical therapy and, just about anything you can think of. And so I think that kind of diversity coming into the specialty will also help us with a different type of view of how orthopedics should be practiced, and maybe even a more of a view towards orthopedics and population health.
Right.
How do we fix things for a community of people versus how do we treat one broken bone at a time? And I think that the younger generation thinks more that way than perhaps we did or we do. And so I, whether it's global outreach or community outreach or, thinking about the people that you're serving and how can you best serve a group of people, I see that in my son as a mindset, and I think that I see that in the younger people that we train as a mindset.
Very good. Now, we had started into the issues of scope of practice and the physician workforce shortage issues. Burnout certainly must add a lot to that as well. And then when you add these issues together, you were saying you were getting into how diversification of our workforce is going to enable our profession to more easily adapt and accomplish these things. Can you step into that some more?
Sure. I mean, I think that that's a pretty proven thing in business and other types of professions that, the companies that are most financially successful, the companies that have the biggest market share, those kinds of things are the companies that have diversity on their boards. And it's directly correlated to those things in Fortune 500 companies. So I'm kind of comparing orthopedic surgery to that and assuming that if we have more diversity within our profession, then we will be better poised to solve some of these issues that are coming down the pike within medicine and orthopedics. And we will have more forward-thinking, expanded leadership because of the diverse thought that will be coming through.
What methods can we use? Because a lot of diversity efforts have been somewhat successful, but we still are woefully behind. Understanding there's a significant supply chain issue. You can't snap your fingers and make an orthopedic surgeon tomorrow. But what can we do to improve the efforts that we've already placed, and what can we do better on that?
There's a lot that we can do better on. I think, the number one thing is we need to provide a more inclusive culture within orthopedic surgery. There are pockets of places that do this. Some do it really well. Some are really good at getting people there, but maybe not so good at supporting the people once they get there. And I'm going to start sounding like a commercial, but we have another symposium that talks about not only how are we choosing residents, but how are we supporting residents once they get there, and why residents from certain backgrounds, such as underrepresented in medicine and women, are let go from programs at a higher rate than Caucasian males. And we need to start talking about this, and we need to actually start having an intervention, in my opinion, that it's not program by program, but a national intervention to really look at this and why it's occurring and do something to stop it. Because we need every single person that we bring into orthopedic surgery, we need them to finish a program and be competent. And if we are letting folks go, we are letting down the public, because the public needs every single one of those surgeons coming through. What's true is orthopedic training has always been based on a timeline. And as we all know, some people might master something in 3 years, some might master it in 5, and some might take 7. And until we get to a competency-based training, which is probably a long way off, we have to have a way of supporting each and every individual to get them what they need to get through the program, because we all know that learners are different, and that doesn't mean some are bad and some are good. It's just everyone learns differently. And we need to start looking at that and how we train people to make sure that not only are we getting a diverse complement of people into programs, but everyone is getting through the program. And I think, the big question is generally around how do we choose residents? And, there is a lot of literature out there that talks about the things that predict who is going to do well as a surgeon are more things like grit and resilience, that there's actually an inverse correlation between a high board score and being a great surgeon after a certain point on that scale. And of course, there are going to be exceptions in both directions. I am speaking in, general terms, because this is the type of conversation we're having. But we at Yale have shifted the way we choose residents. And what I can tell you at this moment in time is that the manifestation of that is that we have a much more diverse group of residents in the last 4 years than there were in the previous 4 years. And we've written this up, and we'll be sharing this, or hopefully we'll be sharing this widely. And I'm not saying it's the only way to do things, but if we only focus on board scores, guess what? Next year, we don't have any board scores to look at. If we only focus on letters of recommendation, guess what? We know that those are fraught with bias, that there's studies that have been done that show that letters of recommendation for women, use different descriptors than those for men, and they don't tend to be competency-based descriptors. Same is true for underrepresented in medicine. So if we're using things that are biased to choose people as residents, then how do we know what we're getting? There has to be a more unbiased way of doing this, and there has to be some metrics that actually correlate with what it takes to be a good resident and what it takes to be a good surgeon.
Do you feel that your paper demonstrates a better way of doing this?
I think it does. I mean, what I can tell you for sure is it has definitely helped us get a more diverse class of residents over the last 4 years than we did the previous 4 years. And Yale is a place who's always, I mean, I didn't start this at Yale. Wayne Southwick started it at Yale, that he felt diversity was important and has always been a program that valued that. We're trying to tweak it and do one better on that. And, if you look at who we've matched into our program over the last 4 years, it's pretty clear that we've been able to demonstrate that in just tweaking the way we look at applications. We look at every single application, all 900 of them. We don't have a board score cutoff. There's lots of things. There's 11-point scale that goes into this, and it's probably beyond the scope of this podcast, but hopefully that'll be coming out. I'm sure there's other programs out there that have better ways of doing it, potentially better than what we're talking about. But I think the main thing is that we start talking about how we're doing this, because if we don't change some things, then we won't have that diversity within orthopedics that we so sorely need.
That's fascinating. I'm looking forward to seeing that because, as relatively new to this process, we were all panicking, but somewhat scratching our heads how we were going to proceed after apparently my place has been using the board scores for decades. And now all of a sudden they are fading away quickly.
Right.
And to your point, the letters are probably not worth the paper they're written on.
Right. So yeah, we're trying to go more towards things that show grit, resilience, distance traveled, leadership, those kinds of things that we desire in our physician workforce.
So as the workforce begins to continue to diversify and become more matching of the populations that we serve and such, how do you feel that this will affect the care that we're delivering to patients in the future in terms of access and quality and all the other important qualifiers you want to give that?
Yeah, I mean, there's no doubt that it will have an impact on health equity and access. There's a lot of research out there that shows that patients want to be seen by a doctor or a surgeon that looks more like them, that has a similar cultural background that they can relate to. There's studies that show that patients are more likely to be compliant if their physician looks like them, and the outcomes are better. And I think in general, that's going to go to quality and safety issues as well. Fewer readmissions to the hospital because patients are more compliant with their treatment regimen, those kinds of things.
Wow, this has been fantastic. I'd like to thank our guest, Dr. Lisa Lattanza, for talking about the generational shifts and worldview changes and how this will affect the future in orthopedic surgery. Dr. Lattanza, thank you so much for joining us and being on the podcast.
Thank you, Dr. Lundy. It's been my pleasure.
Yes, ma'am. And we look forward to other future topics in the Future in Orthopedic Surgery AOA podcast series.